Here's a pretty wild statistic. Roughly 20% of people with type 2 diabetes actually have clinically significant liver fibrosis. And the crazy part? They often have absolutely no idea. It's happening completely silently, right under the radar. Welcome to today's Explainer, where we're going to break down exactly how modern medicine tackles this hidden threat.
And that brings us to a really crucial, honestly often overlooked, reality in medicine. There's a major warning among specialists. Do not rely on abnormal liver enzymes alone to trigger an evaluation. Seriously, many patients with significant fibrosis have totally normal aminotransferases, meaning a routine blood panel might look perfectly fine, completely normal, while a dangerous condition is actively progressing right under the surface. It's a real medical mystery, and the stakes here are incredibly high.
So today we're taking a bit of a medical detective approach to uncovering and managing MASLD and NAFLD. Basically, metabolic dysfunction-associated steatotic liver disease and non-alcoholic fatty liver disease. We're going to decode the exact step-by-step clinical pathway doctors use to find, assess, and treat this hidden culprit before it causes real damage.
Our master plan for this covers 5 main steps. First, identifying at-risk patients. Second, the initial medical workup. Third, advanced testing and referral. Fourth, developing a treatment plan. And finally, long-term liver surveillance. Let's get into it.
Phase 1. Identifying at-risk patients.
So who actually needs to be screened? Well, we're looking at metabolic risk factors that basically act as the primary suspects. This includes type 2 diabetes for sure, but also if a doctor spots incidental hepatic steatosis on a routine scan. Other massive red flags are central obesity, high triglycerides hitting 150 or more, low HDL, hypertension at or above 130/85, or having prediabetes. If those boxes are checked, doctors can actually fast-track the evaluation, skipping the basic ultrasound and going straight to risk stratification to see what's really going on.
Phase 2. The initial medical workup.
Think of primary care doctors as the first responders here. Before zeroing in on fatty liver, they've got to rule out other potential causes. They need to exclude secondary culprits, things like heavy alcohol use, viral hepatitis B or C, certain medications, or autoimmune issues. Once those are cleared, they gather the initial clues through a primary care workup. We're talking a complete blood count for platelet levels, a comprehensive metabolic panel for overall organ function, specifically checking those AST and ALT liver enzymes, and doing a routine alcohol screening.
Okay, so all of those standard lab clues, they're fed directly into what's called the FIB-4 score. Honestly, you can think of the FIB-4 score as the ultimate cheat code for doctors. It's the preferred first-line test because it takes super readily available data, the patient's age, their AST, ALT, and platelet count, and instantly calculates the risk of fibrosis. It's the frontline go-to because of its superior diagnostic accuracy, its brilliant correlation with actual clinical outcomes, and yeah, it's incredibly cost-effective.
Now what's really fascinating here is how a patient's age actually changes the rules of the game. If someone is under 65, a low-risk score is anything under 1.3. But if they are 65 or older, that safe threshold actually bumps up to 2.0. That's done specifically to prevent false positives in older folks. So depending on where that score lands, low risk, indeterminate, or high risk, it dictates the exact next move the physician has to make.
Phase 3. Advanced testing and referral.
But what happens when things get complicated? Imagine a doctor runs the FIB-4 score, and it lands right in that murky middle, the indeterminate zone between 1.3 and 2.67. The initial clues just aren't giving a clear answer. How do they handle that gray area without jumping straight into an invasive liver biopsy?
Well, the answer is second-tier testing, specifically a liver stiffness measurement, or LSM, usually done with a FibroScan. This is the crucial tiebreaker. They literally measure the physical stiffness of the liver in kilopascals. It's kind of like feeling the difference between a soft, ripe avocado and a rock-hard, unripe one. If the stiffness is under 8, great, you're back in the low-risk category. Over 12, you are solidly high risk. This sequential testing is a total game changer because it eliminates the need for unnecessary biopsies.
And zooming out, the evidence-based algorithm for managing MASLD and NAFLD is really a brilliant, intricate map. It outlines exact referral pathways, tracking how a patient moves from risk identification through the FIB-4 score into liver stiffness measurements, and finally into targeted management. The whole system is designed to make sure nobody falls through the cracks while, being really smart about medical resources.
Following that pathway, there's a very clear fork in the road. Low-risk patients can stay safely in primary care management.
But if that FIB-4 score is highly elevated, or the liver stiffness hits over 12, or if there are clinical signs of cirrhosis like low platelets, well, it's time to call in the special unit. Immediate hepatology referral is required so specialists can confirm the diagnosis, manage complications, and maybe even get patients enrolled in clinical trials.
Phase 4. Developing a treatment plan. So how do we actually fight back against fatty liver disease? The absolute foundation, and this is universally agreed upon, is a 7 to 10% weight loss goal. Hitting that 10% target through lifestyle modification is just incredibly powerful. It drastically improves liver steatosis, cools down the inflammation, and can literally reverse fibrosis. It is hands down the single most effective tool we have. Getting there requires a very specific lifestyle action plan. We're talking adopting a low-calorie Mediterranean diet, plus committing to at least 150 to 200 minutes of aerobic activity every single week. And it goes beyond just diet and exercise. Patients have to achieve tight glycemic control and aggressively treat things like hypertension and dyslipidemia. It's a heavy checklist, for sure, but optimizing that whole metabolic system is what actually turns the tide.
Now, for some, lifestyle changes just aren't enough. And that brings up pharmacological therapy. Doctors might look at pioglitazone to improve steatohepatitis or vitamin E for non-diabetic NASH. GLP-1 receptor agonists are proving absolutely incredible for driving that essential weight loss. There are also emerging therapies like seraglitazar in certain regions and even bariatric surgery for morbid obesity. But here's the major pitfall. Right now, there are no FDA-approved therapies specifically designed just for NASH, the older term for the more severe, inflammatory stage. The whole strategy has to be about treating those underlying metabolic drivers.
Phase 5. Long-term liver surveillance.
Managing fatty liver disease isn't a quick fix. It's a lifelong commitment. And the surveillance really depends on the patient's risk level. For low-risk patients in primary care, it's pretty relaxed. Focus on cardiovascular health and simply repeat the FIB-4 score every 2 to 3 years. But contrast that with cirrhosis patients seeing a hepatologist. They need aggressive monitoring, meaning an ultrasound every 6 months to strictly screen for liver cancer, plus endoscopies to check for varices. The level of danger absolutely dictates the level of watchfulness.
So let's summarize the core logic of this whole clinical pathway, because it gives us a really clear, empowering mental model. Screen the at-risk populations. Stratify the risk using smart tools like FIB-4 and LSM. Refer the high-risk patients to specialized hepatology care. Surveil everyone based on their category. And continually treat those metabolic drivers.
Which leaves us with a pretty provocative question, inspired directly by the medical guidelines. Are you waiting for abnormal liver enzymes to start screening high-risk patients? Because as we've seen today, relying on normal test results can completely blind us to silent, significant fibrosis. It's time to follow the algorithm and look deeper. Thanks for joining me on this explainer, and keep exploring the science that keeps us healthy.